Okay, thank you. Well, good afternoon, everybody. Welcome to the December meeting of the Integrated Care Partnership. This is our 4th meeting of the year, so thank you all for your attendance over the year. I'm just spotting that I think there are some newer faces around the table, so it might be helpful just to introduce ourselves. If I introduce myself first, I'm Sue Symington, I'm the chair of the ICB and also the ICP.
Hello, I'm Amanda Bloor, Deputy Chief Exec.
Hi, I'm Hazabrook, Executive Director of Communications at the ICB.
Hello, Helen Kenyon, Place Director for North East Lincolnshire.
Afternoon, Erica Daly. I'm the Place Director for Hull.
Good afternoon, everybody. I'm Karina Ellis. I'm the Executive Director of Corporate Affairs for the ICB.
Hi, I'm Matt Bradley. I'm Acting Place Director for North Yorkshire. Executive Director of Strategy, ICB.
Hi, I'm Linda Chambers. I'm the portfolio holder for Adult Services, Public Health. I'm the Chair of Health and Wellbeing.
Charlie Jeffrey, Vice Chancellor of the University of York and Chair of the Futures Group of the ICP.
Katie Brown, Director of Adults, North East Lincolnshire Council.
Hi, I'm Alex Steele, North Lincolnshire Place Director.
Hello, I'm Simon Cox, East Riding Place Director.
Good afternoon, Councillor Stan Shreve, Deputy Leader, North East Lincolnshire Council and Portfolio Holder for Health, Wellbeing and Adult Social.
Good afternoon, everyone. I'm Victoria Lawrence. I'm the Director of Adults and Health at North Lincolnshire Council.
Hi, Sarah Coleman-Lovell, Place Director for York.
Hi, Councillor Jonathan Owen, Chair of the East Riding Health and Wellbeing Board, Vice Chair of the ICB, Government Partner Representative on the ICB. So I think that's enough. Thank you. Cheers.
Thank you, Jonathan. And welcome, Brick Chan. We can see you on screen.
Hello,
Good
everyone.
afternoon.
I'm Brick Chan Ramratan, Interim Director of Adult Social Care and Health in East Riding.
Thank you. We've got a very interesting agenda today. Let me just give you apologies before we get going. Apologies from Stephen Eames, from Councillor Steele's Walshaw, from Matt Dukes, from Ian Floyd, from Sarah Story, from Rob Walsh, from Richard Hannigan, and from Karen Pavey, although I think you're deputising Karen, aren't you?
I am.
So that's great. And Sarah, you were just talking out to me that
Yes, there is a meeting of the Directors of Adult Social Care and Director of Complex Care in the ICB this afternoon. So hence some of our Directors of Adult Social Care colleagues have sent apologies and I think might have to step out early as well, possibly.
3:30, sorry.
3:30. Okay, well, let's see at what pace we can work. I'm going to ask you, having seen the agendas, are there any declarations of interest from anybody, please? No, thank you. And can we look at the minutes, please, of our previous meeting? I'm going to go through these, asking you for matters arising that don't appear on the agenda, but also any accuracies. So we're starting on page 3, 4, 5. Simon.
Sorry, I'm down as apologies, but I did attend the meeting. It was for the second half.
Okay, we've got that. Thank you. 5, 6, 7, 8, 9, 10, 11. Well, what a great set of minutes if nobody's got any comments they want to make at all. Are there any matters arising which I don't know yet about, or any matters of any other business? No, okay. So we've got a number of quite important papers later this afternoon, but you're going to have the 3 quite usual update papers. One is around the Futures Group, which has met this morning. The second is around local government and where we are with local government, and the third is around the Integrated Care Board report. And then we move into 3 more significant items. One is around design for the future. So this is the proposed future design of services in Humber and North Yorkshire, and you'll see that executives are prepared for that. Alex will talk with us about the integrated neighbourhood approach, about which I think we all need to know a lot. And then Pete will talk some more about the children's plan framework updates. There's some quite important pieces of work going on there. But let's just begin, shall we? Karina, I think you're providing the Futures Group report.
Thank you, Chair. I think it's probably a little bit of an error on the.
Is it Charlie?
Yes, it will be Charlie. I think we maybe thought we'd got Charlie's apologies when the agenda was prepared, but Charlie is here. So over to Charlie, I think.
Brilliant delegation.
Yeah.
Charlie, do you think you might just remind people what the purpose of the Futures Group is just before you kick off?
Yes. I think it is about finding the space, working with partners of various kinds to think beyond the very short term. And through that, to identify things that NHS and partners might do, which can help prevent interventions later by doing things now, to help prevent things which are more intrusive to the individual, more disruptive to the collective capabilities of economy and society, and more expensive for public services, including the NHS, to address. So I think that's roughly what we're there for. And I have to say there were some extremely strong echoes of that sense of purpose in the big speech that Wes Streeting gave to NHS leaders. And I was, or Sue made us listen to the speech last week at the ICB. And I took 3 quotes from it, which I think are really quite striking and challenging. 1, keep patients healthy and out of hospital. So not hospital is message 1. Second is a really hard piece of language, I think. You don't care about the social determinants of ill health if you only ask for more money. I think he said that in a more polite way when he said that every penny spent on treatment is a penny not spent on prevention. And I think those pretty tough words help to express the intention of the Futures Group to nurture ideas and through that to generate potential projects that the NHS and partners can take forward that shift the focus into prevention. So we've had, we're now on a second project. The first, we discussed the progress of this morning, but it's gone really from Futures Group developmental thinking into application and implementation within the NHS. And it's a project that we have called Connected Humber and North Yorkshire. And it's about harnessing the power of health-related data alongside data generated through the educational sector, in housing, in social care, in policing, understanding the interactions of those different kinds of data to show essentially what drivers of inequality are, and therefore what might be done to prevent those inequalities from emerging, and all those effects on the individual, on society, and on the cost of delivery of public services. I have to say it's moved on enormously. I'm very grateful to Pete, Karina, and colleagues for really grabbing hold of this. And I think it's in a place now where data integration is becoming real, but it's also connected it reflects another kind of connection that we have to be really focused on. This is at one level about data science, clever stats, which help us to identify patterns which we can then respond to. And that's very abstract. It's got to connect into communities for that data science to have real grip on people's lives. It's got to be trusted. And one thing that's really, really evident this morning was the conversation with Helen and Sarah, the 2 places which are looking to do some first pilot work on this around special educational needs and disabilities, that connection into communities is being built. And I think receiving enthusiasm in those communities when this is fully explained. And that's really, really positive for the prospects of this to have an impact on the ground. The other thing we heard was that this is capturing national attention, and we have the benefit of an extraordinarily driven and charismatic academic called Mark Williams, who's been a key force in this, who is grabbing the attention of the Secretary of State for Education, grabbing the attention of the interface between DFE and the Department of Health and Social Care. And we're going to be convening through Pete a national reference group of some extraordinarily high-profile figures who I think will help us to position this as something that others should emulate. You know, the kernel of ideas that were developed in the Futures Group is now being taken forward by colleagues around this table in a very effective way. The second programme that we have been developing, and this is in the ideas and nurturing stage. We hope to have it ready for discussion at the ICB with potential funding implications by June next year. And it's about coastal aging well, echoing the language behind me here. And it's focused on some of the particular characteristics of coastal communities in our region, and older generations in our coastal communities, where we have a mix of two things: the general relative isolation of those communities with impact on access to services, but also an in-migration demographic, which leads to lots of people taking their retirement in communities like Scarborough or Bridlington, often with a particular kind of social background, and often bringing a whole range of health inequalities with them. My health scientist colleagues get quite excited about the multi-morbidities in places like Scarborough, because it's a fascinating place to understand how a lifetime of inequality impacts on getting older. The project is the programme of work that we are developing is broadly about how you can bring services delivered at local levels, whether through the public sector or through voluntary sector organisations, or indeed through private businesses, in connection with technology and in connection with genuine, deep community engagement, to open up ways in which active, independent, healthy life can be extended, and therefore the pressures on public services can be reduced or at the very least delayed until later in life. We committed last time, we met 3 months ago, developing this programme of work, first of all in Scarborough, Bridlington and Grimsby and Cleethorpes, so in 3 of our places on the coastal strip, with view in due course to thinking through how some of the lessons that we develop in this could be applied to healthy ageing in rural communities, so relevant to much of the rest of the ICS region in due course. We have since decided we're going to take our very first step in Scarborough. Karina and her colleagues have done an extraordinary job in building a set of relationships in and around Scarborough, which give, I think, this programme of work real prospect to prove the concept, as it were, with the ICB really convening in a way that I don't think otherwise would be possible. Now, that's involved place directors. Mark is a key participant in this, but the other place directors have, even if they're not necessarily involved in it, they're also engaged in that process. We've looked at really innovative work going on elsewhere, in particular in Plymouth, where there's been a brilliant nexus between university housing provider and technology solutions to construct what they've called a living lab, about how older people can harness the power of technology, begin to trust technology in a way which might not be obvious to them, to enhance their independent living and well-being. And we've found a quite extraordinary alliance, I think, Karina, with an organisation called Sea Change, a voluntary sector organisation in Scarborough, with a very close relationship to Age UK, which is thinking in this area already. And there's a ready-made alliance, gives ready-made deep connections into the community. So the plan is really to develop this proof of concept project, as it were, in and for Scarborough over the next few months, and to present that through to the ICB next year. With view to doing that, we have not quite nobbled everybody yet but we will do so for a small steering group to take forward the authorship of this proposal and make sure that we get that connection between technology, services and community in the right place. And it was very interesting. It opened up a conversation at the Futures Group about how this kind of work can provide the prompts that I think the NHS needs to move some of its resources away from treatment and into prevention. And if we get this right, with interventions in and with and for the community, which might, for example, lead to fewer hospital admissions, which might lead then to fewer challenges in providing social care for those who become unable to look after themselves independently. You can see the prospect of real savings, whether to the NHS, whether to local authorities, and of course to individuals who may need to pay for social care. And then that produces, if it works, a real business case for a change in the allocation of resources in the NHS. So it's a smallish town, but with a project with big ambitions.
Charlie, thank you so much for describing that. The thing that I was particularly interested in that, because it can be a bit of a stumbling block for us when we talk about transformation and then comms and all the rest of it, is this assumption that because you're older, you're not going to be able to master technology. Now, that isn't a given, is it? There are many examples of people who are more mature, who are just as easily able to grasp technology, and probably only can't because they haven't been taught, haven't had the opportunity. So getting on top of that seems like such an important thing to do, because it can be a rate limiting factor, and we need to do everything we can to prevent that from being so, I think. Any other questions or comments for Charlie? Simon?
I mean, just as an aside, just on that issue that you raised, Sue, in a coastal area, we had a couple of really very well attended sessions in Bridlington around the use of the NHS app. And what was interesting was the feedback from largely elderly people who attended was that they wanted to use technology, but they would benefit from an in-person hand.
Yeah.
So in the sense of they didn't want somebody saying, this is the website that teaches how to use the app. If I want to use the app, if someone can sit with me for 10, 15 minutes, then I'm ready to go. So, and the demand there which is run by the practice was like 10 times more than they thought. They thought there'd be a handful and there would be queuing out the door.
It strikes me, though, the magical partnership there, isn't there, between young people who intuitively use phones, who actually could, would really love to do something useful with what they know. They don't even know they've got a skill, do they? That's just how they are. And bringing those two together, that would be a very, very perfect marriage, wouldn't it? Anya?
Very quickly, building on Simon's point, but very relevant for ICP colleagues. In the engagement that we've recently done with We Need to Talk, that came out very, very clearly, particularly from our more older residents. But a key piece that came out was actually the role of libraries. And so many people are using libraries, again, to access some of the skills and information to enable them digitally, which was really interesting. I'm really interested in finding through that work.
Yeah, definitely something to do there, isn't there?
Yeah.
Any further questions? Yes.
It's reflection, really. What we tend to forget is, and I'm speaking personally, is that some of us are now reaching that older generation age. Yeah, we're used to using IT now. No, seriously, I mean, in 10 years' time, I will be just short of 80 years old.
Yeah.
So we're only talking about 10 years before a generation that's used to using IT.
Yeah.
It'll be just
No, you're absolutely right. Yeah. You're absolutely right. Charlie, also just to thank you for leading that work for us. We were so pleased when Charlie agreed that he would lead this work, and it's turned out to be a very good move. So thank you for your work. Are you staying or do you have to leave?
No, I'm staying.
Okay, that's lovely. If we move on to item 8, this is the local government partnership report. Councillor Shreve is going to kick us off. Be very surprised if Jonathan doesn't have something to add. But we're interested to hear about your world over the course of the last 3 months or so.
And I'm sure you'll find our world as interesting as we do. I'm going to talk for a very short period of time, but in a number of dimensions. So just to pre-warn you, I'll be talking about devolution. I'll briefly talk about the white paper, but not in any detail, because I think Peter's covering it in more detail later on. Oh, yeah. I'll then talk about something that I've mentioned at a number of board meetings, the Section 75, but I'm going to look at it from a different dimension. I'm going to look at it from the way that it works. Okay. And then I'm going to finish off by looking at some purely local NEL issues where we need help.
Okay.
So starting off with devolution, Greater Lincolnshire and Hull and East Riding have now both achieved a mayoral devolved status, and the statutory instruments have been laid in Parliament to make that happen. I think on both sides of the river, the candidacy for the elections has been selected. I went to a hustings in Lincoln. I was amazed to find that over 250 people attended that.
Wow.
That is really good. I was dismayed by the age profile level.
Was it more mature?
So devolution is a thing now. Over the course of the next few months, it will begin to operate in shadow format in February, I think, and there will be mayoral elections in both of the areas in May of next year. What is worth mentioning, especially in this area, is there's a very strong economic zone called the Humber. And although devolution is different for both sides of the river, the common need to have a successful Humber estuary and all the industry that brings is still clear to all of us. So the Humber Leadership Board will continue, and when elected mayors exist, they will join the Humber Leadership Board. And the Humber Leadership Board comprises of local authorities, industry representatives and mayoral representatives, and it will be the engine room for the continued development of the Humber. That's all I'll say on devolution. The white paper obviously features great swathes of information about devolution. And the only thing that I will say is that when it comes to mayoral powers, for the first time, we see health, well-being and public service reform as something within the mayoral gambit, which is totally new.
Yeah.
And it'd be very interesting to see how that plays out, but I'll defer any further comments on that for a moment. Section 75, we've talked about it, and I've made the plea in the past, don't forget that if you're delegated, then do delegate this. But what I would like to say is, how does it actually work in the local area, certainly in North East Links? First of all, you've got a pooling of budgets, and the largest single budget in North East Links local authority is adult social care, which is 65+ million. And that's pooled with money that comes from the ICB for mental health, etc., etc. And we have the joint committee in North East Links, which is will become the engine room of making sure that we continue to work together. And at its best, what you're seeing now is that the key elements of community care, mental health, even primary care, working much more closely together to ensure that we don't have the confusion of umpteen people calling on a patient for different reasons. And even better than that, it's now cascading very clearly into the voluntary sector, which is critically important going forward. So we all use, and I've heard the expression used here, co-production on many occasions. I'm really pleased to say that I'm seeing it. I mean, and I've attended a number of events, and you were there, Helen and Katie, that you've been at them too, where the product of co-production is beginning to be seen. It's really critically important. So that gives you some idea of the way that it works locally. I know the ICB at regional level is schizophrenic on this issue, because at the end of the day, they control the money. Yeah. So there is the temptation, especially when you're looking at what is the most effective way we can use that money, to start saying, well, we should put that over there. I'd urge you not to. And I think if we talk about co-production, just make sure that we do things together.
Yeah.
Yeah. And I think it's critically important that we remember that and that we do that. Here under the lecture on Section 75. But it'd be interesting, because I know this is a model that we're looking to put right across the ICB. And if any of my colleagues from other places want to come and see us and talk to us about the way that we do things in North England, you're more than welcome. And I might even try and help you along the way. The final thing I'd just like to cover is purely local. And this is purely local. I make no apologies for this. There are certain areas within North East Links where we do not have parity. And I would mention particularly children's services, SEND and things like that in children's services, also public health, where through either an accident of the algorithm that gives you the money, or by a misunderstanding of what deprivation is, we are under-resourced significantly compared with other places in the region. And it's something that at ICB level, as far as we can, where it's health money, we need to start thinking about that. The public health challenge in North East Links, well, for all of us, in North East Links, cannot be underestimated. We're in a sad position where our life expectancy for males has actually gone down in the last decade, because of the degree of deprivation. And Charlie mentioned earlier some of the projects he's got, and he's got a project in the most deprived ward in North East Lincolnshire, which is very welcome and providing a great help. But those things we have to address. So ICB does need to look at that with us. On a more positive note, we've embarked on over the last 2 years with funding from the town's funding from Levelling Up on the biggest regeneration programme that North East Lincolnshire's ever seen. The transformation of our town centre from a pure shopping centre into a community hub with the diagnostic centre, with a 5-screen cinema, and with restaurants and food offerings as well as retail, it's gone through the full journey and was finally approved at full council last week. And the only reason it went back to full council was because inevitably, because of the 2 years that we lost because of COVID, which, let's remember, we all lost 2 years for COVID, and the impact of other aspects on the cost of manufacturing and the cost of production means that our borrowing had to be somewhat higher than originally planned, which meant, and I had a slight difference of opinion with the Section 151 officer on this, that we had to go back to full council to get approval. I personally didn't believe we had to, but I was persuaded. And we had a full council meeting last Thursday, which started at 7 o'clock and finished at 1:45 the following morning. And the first 2.5 hours, and it was the first of our council meetings that was streamed. So the first 2.5 hours was on that very subject. And it was a very animated debate with some very forthright views. In the end, we got the vote that we needed to press all the buttons. So there'll be now complaints for the next 2 years that the whole town looks like a building site. And I'll stop at that point.
Thank you, Stan. Peter, do you want to raise something?
Maybe to respond, Chair.
Yeah.
Let me go pick up a few points. Stan's right. The Section 75 is, I think that's a great place to just note, and your offer, Stan, of supporting other places is very welcome. It is just a vehicle. It's just a way of managing a conversation around some money. I think the critical point that you touched on there was around the relationships.
Yes.
To give you an example, municipal officers previously this week were seeing a young person beyond 18 who would have fell between anybody's responsibility, who needed a service in that moment, getting it resolved because a statutory officer and a provider chief exec were able to just talk. And had that been in another system, you might have seen that thrown into process for a long period of time where nothing ever happened. So you're not going to do everything on a case-by-case basis, but it's the relationships that allow that to happen. The bit I would echo is it's also about the determination of leadership in an area to work together in that way. And then just to kind of follow that through in the way that you referenced Children's Services and SEND and Public Health, they are not ICB versus local authority versus these are our agenda shared. And it's interesting then to kind of, I want to roll, Chair. I'll flow this through into the bit about the evolution white paper, if I may, just to kind of finish that on. Is the two white papers that we've seen in the last couple of weeks, the Get Britain Working and now the English Devolution white paper, we are seeing the mission-led government at work now, because we are seeing the commitment that health will be health in everything. So in the Get Britain Working white paper, we saw mayoral combined authorities taking on duties around inclusive growth, which includes health, and how they're going to convene to support people back into work and to retain in work. And it's particularly pleasing that York and North Yorkshire have the trailblazer for that. So we're pleased with that. And then the devolution white paper. It's interesting that this language of strategic authority is now sort of settling, isn't it? In the same way as the ICB is being referred to as in the strategic commissioning space again. So you can see there's a natural relationship there. There's a couple of things to pull out. The duty on mayoral combined authorities, the strategic authority to take account of the social determinants of health. So exactly what I think Stan's referring to around joining up housing, transport, economic opportunity. That's, that seems like a step in the right direction. And then we will have to consider how we make accommodation for 3 mayors in this partnership here. There will be an expectation that they'll be at the table. And over time, we might expect that that might challenge even some of our boundaries, because as local government reorganisation happens over time, that will
naturally start to have an impact, probably more in Greater Lincolnshire than anywhere else, because everywhere else we've got the unitary authorities, and whilst we've got the unitaries in northern Lincolnshire, how that plays out in the context of the whole of Lincolnshire will be interesting to see. So I think just a position that those are areas that we will need to keep an eye on through this.
Yeah, just to respond to your response. I mean, when the devolution deal was being put together, when we were looking at the business plan behind it, we also put a lot of work into governance, because the situation that we sought to avoid and seek to avoid and want to avoid is a situation that was referred to by a number of people at the recent LGA conference, where the mayors lose touch with the area that they're mayor of, and start to behave like dictators, frankly. And that's not the way it should work. Now, the way that governance will work in Greater Lincolnshire, the voting will hopefully prevent that. In the three unitary authorities have sufficient votes between them to vote down anything that the mayor would want to do that was not in the interest of the county. And I think we do have to bear that in mind, because the relative obsession with mayors and the increase of mayoral powers is something that we have to watch really, really carefully to ensure that they don't lose touch. And especially if you look at Greater Lincolnshire, which is a massive geographical area, it's quite easy to find yourself in an ivory tower and ignore what's going on around. So just sound that warning.
Yes, Jonathan.
Lots of it's been said, so I'm not going to repeat much of the stuff that Stan said and Peter to a certain extent, just maybe add a little bit to some of the items.
Sure.
Talk about section 75. In principle, the Cabinet's been through it in East Riding. Thanks for a lot of help from Simon as well, putting a case at a place level to us, which was well received. I think everybody's of the opinion that it will be a different arrangement in each of the 6 places at the end of the day, because it's how we work together in partnership in those areas and what the priorities are in those areas. Opportunities, I think, touching on public health, that's a good forum to absorb some of that public health preventative work across the NHS and local government, because we are, in fairness, I'll be quite honest, struggling with public health. We are, everybody's the lowest funded, isn't it, when we talk about these things, whichever authority you come from. I think we are bottom of the list in terms of public health funding, which has had a lot of positive inputs, because we do a lot with a little bit of money, quite efficiently. But already now we are using those reserves, which only last a couple of years, that were built up following COVID, actually, to shore up our adult social care and children's services, which is not sustainable in the longer term, but will see us through probably the next couple of years. I think talking about devolution, I'm not going to say any more about it, other than things get very politically febrile when you have anything to do with politics. And although the health service isn't particularly the mayor's responsibility at this point, the NHS is always an easy political target when building against cross-party. I'm not saying partisan. It's very, very easy to hit. We had a conversation the other day at our local health and care committee, which Simon's involved in, looking at some of the issues in the East Riding and how there's a lot of negativity because politicians sort of breed negativity sometimes in, say, hospitals, etc., etc., etc. And I think there'll be quite a lot of work communication-wise to do to sell some of the positive stuff that's happening, even in some of our more deprived coastal areas, because there's lots of good news in there. It's always swamped, especially when politics comes into things over the next few months. Prevention, again, I've just highlighted that, it's key, and the message is stronger and stronger about that. And now I think, talking about prevention, wider determinants, this is probably the best opportunity we've had to push that agenda across the board for years and years and years. It's always been there, but always forgotten about. But the Secretary of State and others have still got that high up on their agendas. So it's how we work together on that. And getting parochial, one of our big issues, and it's a national issue and it's a local issue. Cost of social care, adult social care, provision fees, etc., etc. Probably is our biggest expenditure as a local authority, the biggest pressures on our budgets. There are no easy solutions. You know, we can look at ways of cutting back, but touching on, I know Brickshand, who's on the call, he's been very keen to look at how we use the voluntary sector in terms of prevention and working on that. I have concerns, we've discussed this over the last few months, about the sustainability of parts of that voluntary sector and have the capacity to deliver longer term to replace some of our services. But, you know, it's certainly a discussion that needs having a sort of grown up way, and again, between the NHS and local government. And of course, we've got providers in the care sector looking for increase in fees because they are seriously being hit by the uplift in national insurance contributions and minimum wages, etc. So never forget that sort of demographic of the post-65 population over the next 5 years plus, which is sort of is going up like that. So lots of pressures there. So I'll say no more because I mean, Stan's covered it very eloquently as usual. But of course, you've got Linda and Michael on the call. I don't have any additional comments to make. So.
Anything, Linda?
No.
You know, when we first started off working together, which is 2.5 years ago, isn't it? We talked about the importance of the ICP and the importance of the ICB, and we all saw what happened. The ICB was the thing everybody wanted to join, wanted to be part of, and it looked like it was the most important thing, the most important governance forum for the integrated care system. But actually, I always knew, and I think many of us always knew, that in the end, the real strength and power would lay with the integrated care partnership. And this devolution adds to that, doesn't it? This change that you're describing, this coming together in ways that we couldn't easily have imagined 3 years ago. So I'm very interested to hear about all that. It will change the shape of what we do and how we think here in the integrated care partnership. And it will also influence what we do as an organisation, the ICB. So for the first time, we see what's happening in local government as being absolutely material to what happens within the ICB. And in turn, of course, whatever we do will be material for local authorities. So it's very, very good to get that update. And I think actually, oh yes, go on, Jonathan.
Let's go to add to that. So we touched on it very lightly at the ICB meeting, where I just said rather flippantly, you know, the ICB meets monthly or thereabouts. You know, so I don't know how many meetings we've had this year. And and as you said, this is our 4th meeting.
Yeah.
Somehow I'd like to see it the other way around to a certain extent. It'd be nice to meet as place partnerships 12 times a year and the more strategic one.
I accept that. No, it's a good point.
I think it's just been, we just need to be careful we don't make it too reductionist to the ICP as a local authority and NHS construct.
Yes.
And I'll give you a really practical example of that. Conversations with the York and North Yorkshire Mayoral Combined Authority around the health and work agenda. It's not a two-way thing. You know, University of York are heavily in there through the York policy engine. So straight away there's a 3-way relationship, and I'm sure if we actually mapped it out over time, it will expand and expand. So we have to have a way of keeping hold of, without becoming a massive group which meets in a conference room every month. We have to have a way of making sure that we are stretching into the system in such a way that we have assurance that the plan that we've agreed on behalf of the 1.7 million people of Humber and North Yorkshire is transacting in the way that we expect it to with our combined resources.
Thank you. Did you say something?
No.
Well, let me give you our ICB update, because actually it brings all this together a little bit more closely. And in fact, the first thing I've written in my notes, I've said we start to feel the impact of change in government now in our own organisations. And I think we've had the benefit, haven't we, for a number of years of real kind of centrist governments where, we've had Tories for a long time. There was a kind of centrist feel about what was going on, but there's a real change, I think, isn't there, in the way this government wants to operate. And the impact of this new government is felt both in the ICB and will also in the ICP. So a few things, just to rehearse with you, things I think you probably know already. We quote West Streeting. Charlie's done it already today. I'm going to do the same again today. We've got very, 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 very clear leadership from the Secretary of State. That's quite different to having very clear leadership from NHSE. So you see government and our regulator working much, much, much more closely together than we've ever had before. You can see it's with one voice. a recent briefing that Amanda and I watched had, where Streeting sitting absolutely alongside Amanda Pritchard, who is the chief executive of NHSE, and to coin a phrase, there wasn't a cigarette paper between them. So real change there in the tone and shape of leadership. Where Streeting has spoken about 3 left shifts in respect of the NHS, moving from hospital to community, moving from analogue to digital, and moving from sickness to prevention. Now, this just couldn't be clearer. And more than that, he's described ICBs, ICSs as the pioneers of reform. So these 3 shifts will be the responsibility of this organisation working with others. Very clear, hospital to community, analogue to digital, and sickness to prevention. So if we're looking for things that we think are priorities, bingo, we've got them. He also talks about another kind of devolution. He talks about a triple devolution in the health service. So power from the centre, meaning NHSE, to ICBs, to patients, and to providers. So a further devolving of power and the devolving of influence. We've worked really hard to attempt to listen more and better to the patient voice. We're going to need to do much more of that. And listening to the kind of projects that you were describing, Charlie, which absolutely directly involve people, is clearly the way to go. There were a few things that Wes Streeting said around this pioneers of reform piece, which I think are music to all of our ears. First of all, he spoke about the wider determinants of health. The quote which Charlie used, very pertinent there. But he recognises that the health of the population isn't just predicted by what the NHS does. It's predicted about where you live, what you eat, what your parents are like, what your education's like, what your prosperity and your job prospects look like. So he's seeing health in that wider through that wider lens, and we can only welcome that because we know that that's true. He's talked about the science and technology revolution. So he's talking about genomics and all sorts of complex things in that respect. But he's also talking about how do we properly embrace technology to enable us to do the things we need and want to do. So really a priority. He's talked about developing a neighbourhood health service. Now, we haven't heard a lot about that, but my best sense is that's going to become very important. A neighbourhood health service. So that's a bit like probably what we do in place. I think we're probably on our way there, but I think we're going to hear about this being reparcelled as a neighbourhood health service. That I think will be very important for us next year. He also, a subject really close to my heart, talked about developing talent in the NHS. So I think he sees that the NHS absolutely has to, if it's to be sustainable, keep developing talent, moving talent through the NHS. And then the fifth one, which I've referenced before, really hearing the patient voice. And I think that means really hearing it, really listening, really understanding. All of those things actually are right in our bailiwick, aren't they? And if we had values and beliefs in the way we want to operate, I think that all our boxes are ticked with those aspirations. So our world, our ICB world, has been, I think it's been reaffirmed. There was worry, wasn't there, with the change of government? Would ICB survive? Would there be another restructure? I don't think that's coming. I think there's affirmation that as organisations we have to find our way ever more clearly as pioneers of reform. And one of the things that we'll need to do, I've been talking to Stuart Watson, one of our non-execs this morning, is about ways in which we might develop our board, our ICB, and we need to go on and have a conversation about how we go on to develop our ICP too. So how do we get these two things working together better, more effectively, and more aligned to our overall objective? So that's a piece of work which will take place early in the new year. There are, so I'm just going to leave that there. Are there any questions about that? The second thing, which I'll talk about briefly, Amanda might say a bit more about, but perhaps not, is our financial position. The ICB, the system is in a very difficult financial position. huge amount of work going on currently to work out how we might be able to pull that financial back. But if I tell you that the Integrated Care Board feel very, very, very concerned about the financial position, you'll understand that it's a very important matter for us. Some work going on in January, but actually a lot of concern about the financial position. I don't think I can or should really say any more about that now, but it's a very difficult position. The second thing that's really important to talk about, which Amanda will talk about, are the winter pressures that we're starting to feel, where we're at, and actually what we think we can anticipate over the course of maybe the next 6 weeks or so. So Amanda, just over to you.
Thank you. So just to reference the context nationally first, before we look at the position in Humber and North Yorkshire. I'm sure you'll all have read about the quademic that the media are reporting. So that's incidents of COVID, flu, RSV, and norovirus. And as the chair mentioned, there was a briefing on Monday the 9th. And it was unique in that it was the Secretary of State, the Chief Executive of the NHS, and the Chief Medical Advisor to the UK Health and Safety Agency. And the three of them spoke with one voice about the challenge that we're seeing nationally. The message loud and clear, though, was an absolute recognition of the pressure that the system is under, and particularly the NHS system, but actually the wider system in terms of a lot of the winter viruses disproportionately affect the frail and the elderly, and that comes with a lot of challenges that impact into the wider system. So in terms of what we're seeing, earlier presentations this year of respiratory infections, and I've got some local context to come on to. So increasing cases of flu. Last week, it was a doubling every week that they were seeing in the national position. And that causes particular challenges, especially in the emergency departments in relation to patients needing to be admitted, and then the infection prevention and control challenges that influenza brings, and also issues in the care sector and in care home and for care home residents. And those people with comorbidities are particularly at risk, particularly in relation to flu. And there was a very strong message to continue to push and encourage individuals and frontline health and care workers to access vaccination. So it's not too late to get a vaccination. There's a key message around that. And also to think about how we signpost across our system appropriately for people who need to access care. So that's not always an ED, that's not always a GP practice. That could be NHS 111, it could be a community pharmacy, it could be a community group, it could be through ordering prescriptions early, it could be through having a medicine box at home with paracetamol, etc. in it. And I know the team are doing a lot over particularly the next week to work with partners to get that message out. So those winter viruses put particular increasing pressure for our service users, but particularly for our staff across health and care services, and that's across the whole scope of community, primary care and secondary care. And one of the things we've started to see is increased staff absenteeism as we move into the winter period, and that can cause particular challenges, particularly in smaller providers. So the absolute key focus and what came out at the very start of the briefing was the absolute protecting patients' safety, but safety and dignity. So there's a recognition that the way the system operates at the moment, there is corridor care, there are temporary escalation spaces. We need to use that to keep people safe, but the dignity is a key importance. And that was really stressed to the briefing that we got. And so we are taking a number of actions across our systems, including we had a leaders conversation last night across our system with provider colleagues and colleagues from the ambulance service. So an absolute focus on patient safety and quality, consistent with the national message. Finalised our winter plans, their system plans, and enacting those, particularly focusing on flow through the hospital and thinking about discharge and working through our place directors with our place partners and colleagues around that, and making sure that wherever possible we learn from best practice. We talked about Charlie, there are examples of systems that have been under pressure that have responded and addressed that. And we can always learn from best practice and adopt things to fit our environment and support our patients. There's a particular piece of work that's gone live today at Hull Royal Infirmary around an approach to moving to a maximum of 45-minute handover for ambulances. And hopefully the learning from that will roll out into the York and Scarborough sites in the new year. So that it's a challenge, but all of our partners in the system are behind that. So that will be a real improvement. And there's a big piece of work, as you'd expect, working with NHS England and systems across the region. So where we are at the moment in Humber and North Yorkshire, COVID cases are really quite low, expecting a possible rise in January, and that could align with the flu peak. Flu started 2 weeks early, so we're seeing growing cases. It's worse than last year. Flu tends to operate on a two-year cycle. And so more people are vulnerable, and we expect to see that continue to rise through the Christmas period and then the peak potentially early January. And obviously families and friends mixing, we see the cases present sort of into early January. So we're seeing more patients admitted. This causes operational issues in terms of infection prevention control measures and keeping patients safe in hospital. We've also seen really a peak in RSV. The vaccine rollout for RSV has been good, but it probably won't impact till next season. So we need to maintain that. We're expecting RSV cases to dip now, and we're also seeing norovirus, and we're seeing that affecting in the hospital, but also in the community. So we will keep an eye on that. We are in full operational mode around managing winter and keeping patients safe and looking after our staff.
Thank you. Any questions for Amanda? Okay, thank you very much indeed. I was supposed to hand over the agenda to you earlier, Jonathan, wasn't I?
Might as well carry on now.
Oh, all right. Just about to sit back. Of course, I'll carry on. We're doing very well for time, by the way, all. It's in fact, we're about 4 minutes ahead of ourselves. So thank you all for that. And thanks for those updates. It just occurs to me, we're a very small group sharing those updates. Quite a lot of them are internal ICB people. They're important updates, and it would be good to be able to share that much more widely, wouldn't it, with more and better partners. So let's make sure that that's part of our work over the course of the 3 months to work out how we do that. Item number 10, this is to a combination of Peter, Anya and Karina, and this is around design for the future. This is the development of our future design, I think. Is it to you first, Pete?
I'll position it, and Anya's going to do the bulk of the.
Okay.
In a way, Amanda's input picks up quite nicely, isn't it? Because on one hand, we've got the absolute urgent pressures of the moment.
Yeah.
And then when we look to our strategy, we are committed that our leadership should be focused on excellence, prevention, and sustainability. What a gap between the here and now and where we anticipate should we take us. So to resolve those two things, clearly something has to change. And without stealing Anya's headline, the public of Humber and North Yorkshire have mandated for us that change should happen. So what the design for the future does is it's an articulation of, so what would have to be different if we were thinking about mental health in a different way, if we were thinking about learning disability, autism, thinking about a more social model of meeting need, if we were thinking about how our specialist hospitals functions are organised, what would you get where? This all fits in with that shift to the left we talked about already, thinking about really localised neighbourhood approaches where people can have needs met without having to escalate to higher levels. So all of that is in our thinking around a different way of the public experiencing their health and care needs being met. That's what it's about. The mechanisms which are going on, obviously our relationships with places we've heard about, that's evolving, our evolution of resource and decision making into our collaborative, so they've got a stronger voice in that, which brings together some of that clinical expertise into the space of service redesign. But most importantly, talking to the public to say, what is it that you wish to see different in the way that your health and care is met. So that's where we're at. We're going to hear about what the public have told us, and then Anya will sort of take us into and what needs to happen next from our system coming together to then transact that commitment that we now need to make to the public into reality.
Thank you.
Thank you. Could we pop the slides up, please, Lucy? Thank you. I will just talk through the headlines of these slides because you might not be able to see them so well on the screen, but hopefully you will be able to see the key points. So just to set a bit of context, I think most people are familiar with this work, but I will just set the context. So we were actually in Humber and North Yorkshire slightly ahead of the government almost in terms of setting out the principles, the framework for the design for the future, which we didn't quite describe it in the 3 shifts, but those 3 shifts were absolutely part of the narrative and the principles. And so what we wanted to do, building on what Pete said, was before we got too far into the specific proposals around some of the ways that we think services should be delivered in the future, we wanted to test, in essence, those immediate principles with the public to understand what matters most, what are some of those considerations, etc. And so I'll just take you through the headlines of that now. What I will say, and I'll come on to it in a second, is it was a really extensive piece of engagement that ran from mid-October to mid-November. So again, slightly ahead of the national conversation with the public, albeit all of our insight will feed into that national work. It dovetails really, really neatly. Today, I'm going to give you the headlines from the quantitative, if I can get the word out, quantitative feedback. There was a huge amount of richer insight that we got through the in-person activity in particular, but as you can imagine, that takes much longer to collate and analyse. So the full report will be available in February, but this is taking you through the headlines from the main survey. So if we can just move on, please, Lucy. Thank you. So just in headline terms, we had a main survey that was available for anybody to complete, and we had just shy of 3,500 responses, which for something like this is really, really good, and it is statistically viable. And we went to great lengths to try and ensure it was as representative of our population as possible to make sure that we were getting responses from every group within our population. And then, as I've touched on, we had over 50 engagement events, which resulted in over 1,100 in-person conversations, and they were particularly focused on some of our more underserved communities, again going back to the ICP strategy of really wanting to address health inequalities in particular. So it was more important that we knew and heard from some of those groups, and 1.6 million people saw our posts and engagements on social media and online. If we can move on, please. I won't go through all of this verbatim, but the vast majority, 78% of respondents to the survey were from members of the public, but we did also have respondents from NHS staff and system partners. So again, there's a good representation there. So if we can move on to the next slide, please. We obviously across the system do a lot of engagement work, and I'm sure colleagues will understand that sometimes the public do get a little bit fatigued in terms of they feel we ask them lots of questions and they don't necessarily see the change. So what we did as a starting point in the survey was to feed back the known knowns. So we shared with them, we know you tell us that these things are issues. Which of these issues would you like us to prioritise in terms of sorting out? Sorry, I omitted to say, building on what Sue said, we asked first and foremost if respondents felt that the NHS needed to change. And again, the caveat here is that people in the main don't understand health and care systems, so they don't understand which parts are delivered by local authority, public health, etc. So we kept it simple around badging it as NHS, but 98% of respondents, so the vast majority of people said the NHS needs to change. So there's not only a mandate, as Pete said, there's a clear expectation. And then in terms of the 3 known problems that people said they wanted to prioritise solving, First, the long wait to receive advice, care and treatment. Second, the belief that health services don't talk to each other and the frustration that people have to tell their story over and over again. And third, a feeling that health services are understaffed. They were the three main issues. And I'm not going to touch on it today in terms of the qualitative piece. As I say, that will come back in February, but I'm sure it goes without saying that some of the stories we heard were so powerful in terms of the impact that either waiting to even access any sort of information or advice or waiting for treatment has on people, their families, their lives, their well-being, their finances, and cannot be underestimated. This is such a huge issue for our population. And again, I did this at the ICB, but I will do it again, and to really thank those members of our communities that came forward and shared some of those incredibly sensitive, personal, powerful stories of how they experience health and care. If we can move on, please. So we then asked a question that if the NHS receives no more funding, which are the services that the public feel should be prioritised? Of course, we understand this is a very difficult question. It's very tricky for people to make that judgment. But you can see here that overall primary care received most responses, and I think we will probably understand that from a lot of the national work that's been done, that is a very high priority for the public. Actually, it was emergency care that received more first and second priority responses, meaning that for more people that is a bigger priority actually than primary care. And you can see third there that mental health care is the third biggest priority for people across our population. And then if we can move on, please, and I'm really conscious that I think there was a discussion at the last ICP about some of the travel and transport issues faced by our population. So we asked a series of questions looking particularly at propensity to travel. And what I should have said in relation to the previous slide and in terms of what's important to people, actually for most people, transport and affordability transport isn't a top priority. It's nowhere near top priority for the general population. But of course, for some groups, it is a very high priority. But I think that's really something for us to consider in the future, because I think sometimes we think it's a big issue for everybody, and it really isn't. It isn't coming out as a huge priority for most people. But in terms of the headlines around propensity to travel, so most people, so more than 90% of our population, expect to have access to primary care and pharmacy services either digitally, within walking distance, or within a short car or bus journey. Over half of people in our population expects to have access to maternity, urgent and emergency care within a short journey. So again, there's still that expectation, and it links to the priority, I think, on the previous slide around urgent and emergency care. And as we've shared before, also people get confused with the terms urgent and emergency care, because what's one person's urgent issue is somebody else's emergency issue. But there is still a high expectation of that being available in a more localised area. But there was more of an expectation to travel, so beyond 30 minutes for specialist care. So using an example of cancer treatment, 73% of the population would expect to travel more than 30 minutes to receive cancer treatment. And 61% of people would expect to travel more than 30 minutes for pre-arranged hospital treatment. And most people would expect to travel more than an hour or out of area to most people would not expect to travel out for more than an hour or out of area to receive treatment, although nearly a quarter would expect to travel for that distance of time for specialist care. So there's quite a lot, and there'll be a lot in the detail of this data to work through, and obviously some things that we may need to work to change some of people's opinions around that. If we can move on, please. So we asked a series of questions around digital, again, the move from analogue to digital. And again, there's some really interesting things here. So we asked about how people were using digital in all other aspects of their life and in health and care. So people are 6 times more likely to use digital as their default for banking than for managing their health. And I thought that was quite significant, really. And when we think that it was only fairly recently that we made that shift to online banking, and yes, there was a lot of, hoo-ha about it at the time, understandably so from some members of the community, but I think now most people are pretty confident in using their online banking. It is their default for many people, as we've said. People are more likely to always or often use digital for education and learning, entertainment, communication, remote working and online shopping than they are to manage their health. And people are less likely to always use digital for their health reasons and management than all other options in the survey. So there's huge potential here to really use digital. And then the second part of that line of questioning, if we can move on to the next slide, please, is we were asking about the willingness to use digital technology. So we've already understood it's quite, there's a low level of usage already, but are people willing? And absolutely, the vast majority of people were willing to use technology to either help with their care or to improve their overall health and well-being. And as it stands today, they were most likely and most willing to use it for ordering medication. Telephone calls actually ranked quite highly, and the NHS app. They were still receptive but less likely to use digital for video calls, so as an example from their GP, or for other health and well-being apps. But the devil's always in the detail, isn't there? And I think people feel overwhelmed by the volume of health and well-being apps, and I think that's what puts them off using a lot of the apps. They don't know which ones or which one to use. If we can move on, please, and apologies, I appreciate we're skipping through this quite quickly, but I do want to make sure it's all in time. We then asked a series of questions around prevention. As I said right at the beginning, we were working with those very similar themes to the national 3 shifts, hence why you see similarity in the areas of questioning. So we asked people 3 questions, and there were a range of answers that they could choose from. We asked them, firstly, what they thought they could do to improve their own health and well-being and that of their family. We then asked them what they are doing to make those positive changes, and we asked them the things that are stopping them from making those positive changes. So you see the top 5 here, and again, there were a list of about 30, I think, they could choose from. But you can see certainly a correlation between the things that people could do, and actually great because they are doing some of those things. So particularly increasing exercise, reducing anxiety and stress was second. Again, very much that link to mental health, as we know. So second, in terms of what people think they could do to improve their health and well-being, is reducing anxiety or stress. That's above improving diet. And then improving mental health is number 4. So again, a lot there around stress, anxiety, mental health. And what we found was quite surprising at number 5, it was living in a supportive community. And likewise, on the flip side of that, people are taking measures to improve against those things. But the number 5 one, again, linked to the supportive community, was people are trying to make friends and find the support not to be lonely, which again, we thought was really interesting. And again, some of the things that are stopping people making positive changes won't come as a surprise, but motivation and willpower, time constraints, habitual behaviours, financial barriers, and mental health issues. And particularly in some of the more qualitative piece that's coming out, there is this sort of vicious cycle, if I can call that, particularly with people experiencing mental health issues, that that because they can't access the support or they can't take some of the preventative measures, it's having the further impact on their mental health. And that is definitely a theme that's coming out. If we can move on to the next slide, please. These are just some of the things that people were telling us. So I'll just let you read those, but particularly some of those things. There's a comment on there from a single mum, a mum of 4. People in the main know what they need to do, but it's just difficult to do it. So we didn't get anybody saying, I don't want to improve my health and well-being. It's more that they have these barriers and challenges to do it. If we can move on to the next slide, please. So we then asked people, in terms of their health and well-being, what is actually the most important to people, taking it as read that, of course, receiving, safe and high quality services, that goes without saying, but what is really the most important to people? And you can see here the top 3. I will read them because it might be a bit tricky to read. So firstly, I can get the care I need to look after my general health and well-being is number 1. Secondly, my care is centred around my needs and I am listened to. And thirdly, there are enough staff with the right skills and experience. And these things ranked much higher than things like I am able to get there, affordability of transport, services are good value for money, I'm cared for in modern services. These are the most important things, which again absolutely links back to our strategy of being person-centred in particular, family-centred, community-centred. And if we can just quickly whip through these next slides, we should just leave them up for a couple of minutes. So this basically just shows you on this first slide through the lens of our 6 different places, and you can see there, if you remember the colours, you can see it, regardless of place, it's still these things that are important. There's sometimes a slightly different ordering, but it is still these things that are important. And if we move on to the next slide, please, you can see again there from looking through the lens of different groups. So young people, people with a physical disability, people with a learning disability. Again, it is still these 3 things that are the most important to people. And finally, on the next slide, again, those with long-term condition, mental health, system partners and staff, it's those 3 things that are the most important to people. And again, it's really interesting in how we really embed this through the design for the future work that Pete was talking about, because it is, dare I say, the softer side rather than the harder side. It's that person-centred that people really, really want, and they'll forgive a lot of the other things. They'll forgive the fact that they're in an old building if they're being listened to, and they only have to tell their story once. It's all those sorts of trade-offs, as it were, that the public would really accept. And if we can just move on, please, and this is just the final slide. As I say, there's a lot to work through in the qualitative insight, but just some of the key considerations, and as I put there, emerging, because we're still working through. So in the main, people's experience of the care they receive is broadly good, but their experience of navigating and getting into the system is broadly poor. They keep telling us they don't understand our system. I alluded to, how do they distinguish between urgent care and emergency care? To the person on the street, it's the same thing. So the way that we label things, the way that our system works, isn't easy to navigate, and again is compounded when we talk to people where English isn't their first language, etc., etc. And as I've touched on, ensuring a person-centred approach which is inclusive is absolutely key. To have that better understanding of the system is absolutely paramount, so people understand how the system works, where it should go. And what a lot of people talked about was consistency. So they see the variation in services, and the experience of access. That was the thing that comes out mostly in the conversations, is how difficult it is to just get that initial access. A really big piece around the need to build trust and confidence in new models of care. So it comes up time and time again. I only trust the doctor. I don't trust that person when I ring the GP that's asking me lots of questions. So we really can't underestimate, I don't think, as we develop the new models of care, the amount of of effort we need to put into re-educate people and build their confidence in these new models of care. Again, what came up time and time again was people's absolute desire to see a local workforce being developed for our NHS health and care system. And as I touched on in the prevention messages, people really want to do better themselves for their health and well-being, but they struggle. They want better support and advice to live healthier lives. So that was a whistle-stop tour. But as Pete said, and I'll hand back to Pete and Karina in a second, we've presented this in headline form to the Leaders Forum and through the system engine room. And what we really will be expecting to do is obviously go back to the public early in the new year with what we have heard and start to set the direction of how we will be using this. And then we would expect to have much more detailed engagement and co-production, to Jonathan's point earlier, around then how particular services are designed for the future. But this is just giving us that baseline to start thinking in more detail about that work. But Pete, Karina, anything else you want to say on the back of that?
No, really helpful. Thank you. Anyway, the only thing that I would just say in terms of the next steps around the work that we're doing is, as Pete said at the very start, we have a number of pieces of work that are taking us in this direction. There are a series of roadmaps, one of which we're going to hear about in a moment around integrated neighbourhood approach. What we are doing early in the new year is some check and challenge in that space, aligned with the case for change that we set out originally, the narrative that we've got from the public and what we're hearing in that space, checking it also against the strategy and where we said we were going to get to with the strategy, just to make sure, because these have all been running concurrently, that there is alignment and a thread through all of it, and that we haven't got any glaring gaps where we think that we haven't covered something sufficiently enough, particularly in relation to the three shifts that we're hearing about, and making sure that we've got all of that plan. And then, as Anya said, that will then link into the you said we're going to do, or we have done, or we are doing piece back to the public.
Thank you. I'm just going to go Helen, Amanda, and then back to you, Pete.
Yeah, thanks. I suppose I wanted to pick up, in particular on the whole digital piece, because I think, having recently been into the bank, you are constantly pushed to go onto the app. So I wanted to do a couple of things in the bank, and I was with my sister who also wanted to do things. It was sort of, well, you can do that on the app. Have you got the app? Can you do it? And so I was given support to just do it myself, whereas actually my sister said, well, I'm not confident. So she then got an appointment to actually do it. So that whole approach of the banking system is to get you confident and using the app. And I think that we don't do that in the NHS. It's there, but we're not actively supporting people to learn how to use it to maximum effect. And so I think there's some training for the population on that, but I think there's also training for staff around actually how are we encouraging and empowering and enabling people to start to use that.
Or a clever project with young people, as we just
it does. That's right. But I think it's got to be pushed, hasn't it, by the professionals. And so it might not be that they do the training, but actually if you've identified that somebody's a bit reticent about it, then actually you support them into somewhere else, which, like you say, could be a young person or a voluntary sector or whatever. And I think where we get confused in the NHS is this bit between person-centred, which I think a lot of people and professionals hear as face-to-face, versus actually we want to be listened to and understood and heard in terms of what we're doing. But actually, if we can get it via a digital room, but I'm still confident that that's the focusing on me, then actually, again, that's part of that change in culture. I think we've got to collectively go down.
Thank you. Amanda.
My point was also on digital, actually, but coming at it from a slightly different way. And I think that if we think about the level of confidence that there is in using digital and tech for things like booking holidays and banking, accepting that we're on a journey, I just don't think there's the offer in health and care. So you actually, even if you wanted to, you actually can't. And I suppose I've got a recent experience of paper versus a phone call versus digital. and it all defaults back to paper. It doesn't matter if you go and check in online, you're still asked, where's your letter? Well, I've shredded my letter because I got a letter and a phone call and a digital thing. So actually what we're not doing is designing that state-of-the-art digital interface, because we are all going to use healthcare. And as the point's been made, we understand how to use tech, that there is definitely something for me about if the offer's there and the training's in place, we could revolutionise the way we deliver healthcare. And I think that that goes hand in hand with, it's not about patient-facing, patient-centric, being in front of a person. It's about really genuinely what people want and need. And that might be a phone call, or it might be an online consultation, or it might be face-to-face, but we've got to get better at that.
Peter, Sarah, Simon.
To land the point rather than this sounds all very doable, doesn't it? But there are different stakeholders in here, so the public have given us a clear voice. Professionally, we have a view of this, and the glorious technocratic part of the world which we sit in, we might think we know the right answer just by listening to the public. There is also a political dynamic at play here, which we can't underplay. And so part of the work we also have to do in response to this is to work with our MPs and our elected portfolio holders to prepare the ground for this. And I don't want that. I'd rather we were talking about that openly, because it will be difficult. We will have to make changes. And to paraphrase some of the MP conversation we had recently, get on with the change, but not necessarily in my backyard. So there is a bit about how we manage that. We keep an eye on all of those parts. So yes, we are serving the public, but we also need to remember that.
Yeah, thank you, Sarah.
Yeah, thank you, Chair. So I was going to give a similar, make up a similar point to Amanda. I've recently become a patient, and what struck me is that the digital experience in the NHS is infinitely harder than the analog experience at the moment.
Yeah.
So I have the NHS app like 34 million other people apparently in England, and yet I am expected to access and navigate my care through 4 different digital systems, none of which are the NHS app, plus the paper-based system as well. And the weekend I bought myself a notebook so that I could then keep track and navigate all of these different digital systems. So there is something about what do we need to do as an ICB and an ICS to reinforce the NHS app? If 3/4 of the adult population are using it, then why aren't we? And certainly as we start to develop a wider digital system using the NHS app, and not just for health, but for care and prevention, because it is the most widely used healthcare app in the country. So there is something about I suppose influencing obviously nationally. But also ensuring that as we are procuring new hospital digital systems, for example, as we are doing in Humber and North Yorkshire, ensuring that those systems are putting everything through that NHS app.
Yeah, very helpful. Thank you. And Simon.
Thanks. Briefly, just a little bit of balance, I guess, in terms of there was quite a strong view that transport and geographic access wasn't that strong a priority. And I think it does depend on which community you talk to.
Absolutely.
I think access to transport is not that important if you've got access to transport.
Yeah.
So I think 50% of people in our most deprived communities in some areas don't have a car in the household with a disability. So that means it's difficult for you to get into a car if you've got one and you haven't got a car.
Yeah.
So I think we need to probably, I'm not suggesting this doesn't help drive our policy, but we need to also be sensitive to specific communities within the ICB.
Thank you.
Yeah, just very quickly, absolutely. I'm sorry if I didn't articulate that more fully. It was more the point of we sometimes think it's a big issue across the board. It isn't, but notwithstanding, it's a massive issue for certain parts of our population. So we need to work with that. It was just very quickly, Chair, coming back to Sarah and Amanda's point around the digital piece. And again, I think we all understand this, but because most other things are so sophisticated. And I think actually where Streeting makes this point, you know, people's expectation in every age range is then, you know, I can go on Amazon and get something delivered probably later today if I really wanted to, and they'd send me a raft of other things that I might also be interested in, and it would be in language that I can understand. So people's expectations are up here, but their experience of health digitally is probably down there. But there's the added issue with when we're trying to build confidence and build our reputation, you know, if we can't, you know, to the words of some of members of our public, if you can't do that right, how are you going to do that right? And so I think it is a bit of a barometer for building confidence with the public, that actually we can transform not just digitally, but we can transform our overall.
Richard.
Thank you. So my reflection on the feedback from sort of public is about how do we do less of bureaucracy? How do we enable people to have access to services that are much more in line with where people are, and a little bit about kind of being a bit more not just person-centered, because that means lots of things to different people, but it's about strength-based. Lots of people who come to us for services, both in adult social care and in health services, have got a huge variety of support network already there that aren't being used. The risk that bureaucracy faces is that we remove those kind of good support network, and we tend to want to replace them with lots of care and support. And that's because we're not sensitive enough of the kind of ecology within which those people exist, really. And how do we make our services a lot more kind of sensitive to those, so that we are just proportionate in what we're delivering? That's the biggest challenge that adult health and social care services face today.
Thank you, really helpful. The things that leapt out to me, interesting, those priorities, weren't they? Primary care, emergency care and mental health. Wondering, were they predictable? Probably, I think. That's probably how people see their healthcare, isn't it? Very interesting about the travel piece. And I totally accept your point, Simon. Why would you be interested in travel if you don't need to think about it? But there are, and it's a small group of people, isn't it, who are really, really impacted by travel, who live in rural communities and more remote communities. So although for most people travel is a manageable thing, there is a segment of the population for whom it isn't. I know the ICP cares very much about that, and I guess when we're talking about a community health service, that will be part of that too. Yeah, I mean, the digital revolution is inescapable, isn't it? We just absolutely have to face into that now. Interesting listening to us talking about, we all know what to do, don't we, to be a bit thinner, to be a bit fitter, to be a bit whatever. We notice that most members of the public know what they need to do too. So we have to then look at that next bit, don't we, which is about the motivation. What would it be that would motivate you to do it more? And I'm wondering what those sorts of things might be, and also how you might use social media and artificial intelligence to enable people to do that. And the final thing was an observation for me is this one that everybody includes, which says there aren't enough staff, making sure there are enough staff where I'm going. Well, we do know that we've had a 20% uplift in staff in hospitals, don't we, in the last 5 years. So I think we have to assume that broadly there are enough staff. What that tells us is when people go into hospitals, they don't see those staff. They don't seem to be evident in the places that those people we spoke to visited. So it doesn't feel that way when you're a patient. And maybe that's a challenge back to us, really. Why would that be? Why does it not feel that way? I'm really pleased with this piece of work, Anya. Have you got just a minute to say what the next step in this is?
Yeah, so in terms of the actual full report that is being worked up, so that will be available for February. And then, as we touched on, that's going back through to the Leaders Forum to inform the plans and proposals moving forward.
Lovely, thank you. That's great. Let's move on to item 11. Alex, this is you. This is the integrated neighbourhood approach. Do you think this is the forerunner of a community health service? what did you call it?
Neighbourhoods.
Neighbourhood Health Service.
I think it's broader, but I'll pick that up as I go through the presentation, because I think it's about how do we connect all of those pieces together to be able to deliver that. So this is a piece of work that, as Karina's alluded to, we've been looking at through the Design for the Future. Links very nicely with the work that's just been presented by Anya and the understanding and intelligence that's come out of that will be really helpful in shaping a piece of work that we take forward around neighbourhood health and integrated health and care, and how we deliver a model that meets the needs of our population. The national context around this has been really well described earlier in the meeting. So as described, how do we look at shift from sickness to prevention, analog to digital, looking at proactive, not reactive care, approach to care that spots problems earlier, and a care that is delivered in and close to people's homes as well. So that national context and the importance of neighbourhood working nationally, and the importance of integrated care boards and integrated care systems in driving neighbourhood work. So this is a big focus that I know we're all aware of, and it's a focus for all of the partners across the integrated care system in that regard. Really important we take a systems-wide approach to how we do this, because this is much bigger than just health and even health and care, but the social determinants of health. Now we really mobilise our community assets, work with people in communities, understand the needs in communities and how we support people. So I think that's a really important context. If we get this bit right, in my mind, then we really have the ability to create some of the shifts that Charlie, you were talking about earlier in your briefing as well. And importantly for individuals, on the first next slide, just in the diagram, this is about the communities and the population, but importantly, it's very important for the people and families and carers at the centre of this, because personalised care and care continuity is a massively important dimension of what we need to deliver here. Evidenced by population health data, which I'll touch on later, and supported by digital transformation, one of the key enablers that we've picked out in this piece of work, because we can do things really differently to support people. So a little bit about where we are now. So every part of the country, I think, is focusing on neighbourhood working, and we are part of a cohort of a number of organisations across the country, and we are sharing learning on neighbourhood working, which I think is really helpful. Where particular areas have started to drive this agenda forward. So I think that's something we'll be continuing to help support us on that. Locally, we have got some good examples of integrated neighbourhood working that have grown up. Really driven, I suppose, by the Fuller report that I think many of you will be aware of. Claire Fuller's report talking about how we develop neighbourhood working at populations of around 50k population. But what we don't have is that happening and consistently. And when I say consistently, it's about the framework for how we do this. The framework that takes account the really important individual needs of local communities and neighbourhoods. We don't have that consistently happening across the piece. But as I said, we have got excellent examples. We were visited by Tim Briggs and Claire Fuller to look at the primary care pilot, 4 primary care pilots that we have within an integrated care system. Claire Fuller specifically commented that one of the pilot presentations, she said, this is the first time I've seen a really good example of neighbourhood working where all of the components I envisaged in the report are actually delivered. So we've got it, we can spread that. And that was South Humbleton and Rybell PCA who were delivering that piece of work. And similarly, and importantly, how we've looked at this across the ICS is we have looked at how the VCSE, the community collaborative, the primary care collaborative in place work collectively together to do this, because this is for the whole system and with some of the core enablers that we'll talk about. So this piece of work is a co-produced piece of work between those collaboratives and between the places to really drive that agenda. And I think that's really important. And in that regard, key important pieces of work helping to drive this is the work that you will have heard about already around integrated core offer. So again, how do we give a consistent service? How do we make sure that a person on one side of the street can get care after a stroke consistently, and they can't on the other side of the street? So these are very much coming together to help to drive that agenda and the continued work on the core offer. And I think an important component of this is that this isn't a nice to do, this has got to be the default way of working. And from some of the good work that's going on, I'm looking at an evaluation that East Riding were doing around some of the work they're doing. One of the nurses involved in this says it was great to be involved. She could hugely see the benefit, but then said, I have to go back and do my day job.
So actually this needs to be the day job, doesn't it? We need to get people to work in this way. So we have, if we move on to the next slide, identified some core elements that we need to deliver. Just pop onto the next slide, that'd be great. Thank you very much. So, and I'm not going to go through all of the details but we'll pick up some of the key elements because it does chime very well with what we're hearing earlier about what's important to people in terms of the care that they receive. So what we're aiming to deliver through the neighbourhood approach and integrated core offer is that we have services in a community that are targeted and sensitive to our local populations, that we do ensure equity in terms of what people can access, and that we do address those barriers in engagement, choice, and to support people within that. That we do have that safe, effective care as close to home as possible with the right workforce, but truly harnessing the skills and expertise right across the sectors in how we do that, community primary care, VCSE. That we do make sure we deliver continuity of care. So we know this is one of the key issues that comes back out of feedback is that people do feel they're passed around the system. So we need to make sure that that continuity of care is clearly built into the model of delivery, that this is intelligence-led. So lots of work going on with the integrated care system around our population health management approach that gives us the data and intelligence to look at how we can optimise care right down to the individual level of the individual person. So we do know those people who are repeatedly accessing services. That gives us the possibility to identify and support those individuals and giving them proactive solutions to stop that from happening, provide the right support that those individuals need. Massive focus around proactive and preventative. We know we need to make that shift in the NHS to making sure that we are delivering and supporting those, enabling people to access those preventative and proactive approaches to health, and then transformation. And this is the component of driving this through the blueprint-based approach, which is making sure that we have the right leadership, we have the right system architecture, and we've got the right capacity and support to be able to deliver this effectively. So it ceases to be something we do well, part of this in some of our places, but not everywhere. So the universal offer and neighbourhood-based approach, we've looked at 3 core components of system architecture that enable us to do that. So the functions of neighbourhood teams are very much around looking at how we streamline access to urgent care. At the moment, as people have described, often our services are struggling under the pressure of urgent care access, but not having the ability to really look at that proactive model. So how do we manage that urgent care need effectively, generate the capacity to look at long-term conditions management, proactive, preventative approach to managing complexity and long-term conditions, and how we help, importantly, people to stay well for longer through that proactive approach to how we do prevention. So back to the fuller construct around this, generally speaking, we've got our neighbourhood approaches looking at around 50k populations. So one of the key pieces of work that we're doing at the moment is working across the places. All the places already have neighbourhood team constructs that they're looking at, but again, making sure that all partners are connected into those, are working effectively together to do those. And those neighbourhood geographies are the right geographies to focus on the communities and be able to support those communities as well. That's a core element of the piece of work. So again, we're not starting from zero here. What we are doing is really maximising the benefit and making sure we've got those neighbourhoods and geographies really clearly defined and working really effectively with partners across the places. Working really closely with community partners to understand what needs to be delivered at a neighbourhood level, what needs to link into that, but what some of the services may need to be delivered at a larger than neighbourhood based level where scale is important to deliver that. But those close connections into an alignment with the neighbourhood teams is really important to deliver that fully integrated way of working. And then where people do need that more specialist support, they're able to really rapidly access that through the model. And then the system architecture for delivery, so workforce, data, governance, and the wider system architecture is critically important. Critical dimension here around our VCSE capacity and partners, so hence why the VCSE collaborative have been strongly engaged in this, because many of the things that can be done to support people is outside of the parameters of the services, but is about loneliness, befriending, how people are connected into services effectively, and the right support and advice to be able to do that. And lots of that is really important to help people to maintain healthy lives. This is, if we get it right, is a significant and transformational, system-wide transformational change, and therefore we need to think of all of the core components. Thank you. Before on to the next slide. All of the core components that help us to do this. And this is also about the pace to deliver this as well, so that it's not organic, but we do put the right capacity behind this to deliver that. So there's a huge piece here around organisational design and organisational development, because getting teams to work effectively together means that we need to look at teams effectively having that multidisciplinary organisational development support to be able to do that as well. And we just we'll be working with York University as well to do some cross ICS work with PCNs around working with getting teams to come together to look at how they delivered integrated neighbourhood working. So I think that'll be a really positive opportunity for us. Ways of working, effective partnerships are really core in how we do that as well. So building on the partnerships that we have in our places and across our wider system to enable us to deliver that, and effective partnerships with our local communities to support health and wellbeing. Models of care, so making sure we've got clear commitment, which we have through this approach for all of our system partners, to that integrated neighbourhood and core offer approach, and really establishing that population health management right through our system. And then making sure that importantly, we've got the right digital architecture, shared estates, because of course there are great opportunities here for people to come together more effectively in terms of how they work, and we've got shared access to data to be able to support that.
Oh, is that
next slide, if that's okay? I won't go this into any degree of detail because I've probably picked it up as I've gone along, but just for people to get as we take it sort of down the tier, to really understand from the perspective of the neighbourhood view, what are those core components that are really critical to delivering integrated neighbourhood working. And we're just doing some work at the moment to understand where people have their defined neighbourhoods, where are we at, what's our state across those, because some neighbourhoods will be delivering some of these elements really well, some will need additional support to be able to do that. So we've got some very practical stuff going on the ground to look at how do we deliver a consistent approach to that within that framework. And then again, I won't go into this in any level of detail, just conscious of time, but I think always critically important to bring it back to the individual and what this means, if we get this right, what it means for people. And these examples talk about how we've proactively supported people, how we've looked at better continuity of care, how we've helped to navigate people around the system effectively to support that. And at the moment, listening to the feedback that we've had earlier, this is what we need to get right to be able to deliver that better experience. And again, how we work together as a system, I'll just touch on the next slide, is very key. So we, as I said, we've got around 42 neighbourhood teams that we are working across our integrated care system, our 6 places, working with all of the key partners in our place to deliver that. Lots of work going on with the community collaborative, looking at how do we build our community provider coalition so that we're able to deliver that integrated, consistent core offer across community. And then we have a governance approach as well that looks at cross-system approach to neighbourhood design and oversight. And then finally, we have looked at, and this is a headline roadmap, but we are in the process of developing a much more detailed roadmap that sits underneath this to deliver 2 key transformational strands at the top of the slide: integrated neighbourhood teams and approach, and integrated working at scale. But the enablers that sit under this are absolutely critical, because if we can't do that, deliver all these elements, they're all critical elements to deliver neighbourhood working. So population health, data and digital, as we described, workforce integration, estates, and acute and mental health. So the leadership that we have involved in the programme spans right across at the core SROs that look at each of those individual pieces of work to drive that. So this isn't a piece going on there, it's a piece that cuts right across the integrated care system to provide our roadmap for delivery. There's included in the pack, this just describes the governance approach that we are looking at. So the collaboratives, as I said, working really closely together with Place through the Place Design Group to make sure that we can deliver and mobilise the model with the key enablers. And then the final one is just the SRO arrangements as well, so that we are connecting with all parts of the system to be able to deliver this approach.
Thank you so much, Alex. Thank you for accelerating away towards the end. Questions for Alex, please? Yes, Jonathan.
I don't even know what I'm asking with this, but I am reflecting back to very early comments that somebody was doing a bit of work in this role, but had to go back to the day job. I'm just wondering, a lot of these, so I'm going back to previous conversations, you know, in these riding too with public health colleagues, says, oh, we've tried to have this integrated working for 20 years and it all comes, you have a pilot and it all works wonderfully and then it all falls apart. And I think we do think this is the opportunity now to actually make it work. So I'm just saying, do we know where the holes are that need plugging? Because they're filled by people who've got another day job. If that makes sense. I don't think it does to me, actually.
It's a really, really important question. I think there's two pieces of work that are going on to understand where those holes are really. One is the piece of work that the community collaborative are driving around the core offer and getting a really good understanding of what the current position is across the community providers. And then we're also doing a sort of parallel piece of work across neighbourhoods to understand where a neighbourhood team's at, are there capacity gaps, are there issues that are stopping them to deliver? Because until we get that really good understanding of that, people are delivering at a level, but not where our ambition would be in terms of that. And similarly, the voluntary and community sector are doing a piece of mapping work to really understand that. We need to connect that intelligence together, which will tell us where we've got areas where we need to look at infrastructure support, particular gaps to be able to support that. But it's a huge change in workforce behaviour as well, and that needs to be driven through all of the providers to be able to support this, that enables people to focus on making sure that their connection into better continuity, integrated neighbourhood working, complex case management is a key element that needs to be driven. Primary care is really critical within this. As the holder of the registered list, they'll often have the visibility of who those individuals are and the ability to work with the providers to deliver that integrated care model as well. So that's the detailed work that's is now going on to try and understand where we are.
Thank you. Helen and then Mark.
Yeah, I suppose
sorry, Sarah.
I suppose I'm just going to further add to Councillor Owen's question. I think one of the big issues that we've got to resolve on top of all what Alex has talked about is the way that we are asked to record and capture the activity that we're doing across the different sectors. So as we talked about earlier, with having different IT systems, there are lots of different national reporting requirements that are fundamentally opposed to each other. And so quite often when we're in pilots, we'll either put some admin in place to enable people to do duplicate entering and all of that sort of stuff. But we can't sustain that because it's additional cost that we don't need to be doing. So I think there's a really critical role for us as an ICP and the national system to start to try and break and change some of the reporting requirements that actually then enable us to change how we report and work together in a different way.
Thank you. Yes, right, Mark.
Yeah, I mean, for me, this kind of starts with the organisation, the ICP, the ICB strategy, really, because you need that system mandate to get that time and space for people locally to be able to develop this, because actually it's not, while you've got that common offer, it will be different in neighbourhoods, and that neighbourhood and having the time and space for those neighbourhoods to come together, because based on the population needs, the service and the offering will have a different slant on that. You've then also got to go where the energy is as well, because some neighbourhood teams will develop faster than others. So you've got to go and chase the ones who have got the energy to try and prove that case. Very much that joining the dots is really, really key in terms of all that data. And that's the thing that comes out whenever we have conversations within North Yorkshire, and being able to join all that data together. I guess it's then also having the courage and the leadership to stick to this strategy, because the short-term urgent care pressures will deflect us away from the capacity to drive this forward. So we've got to keep that. And I would say this, but you've got to have a strong underpinning financial strategy that allows the money to move and to be able to move it around the system and be able to provide, I suppose, the pound to be able to move resource around. So
Yes.
that would be
Yes.
my take on it.
All very helpful. Sarah, sorry, coming to you in a minute.
Yeah.
Ladies first, Sarah.
Thank you. Yeah, so a couple of points really. So just to kind of give a flavour first of all around the sort of where we are in York, and I think it illustrates the kind of amount of shift this is requiring. And it's a real job of leadership within place to really land this so that it isn't just a vision, that it actually does become reality. So we've taken around 6 months of really intensive engagement to move to a single defined model of what neighbourhood is and what those boundaries are within the place. And that's for community services, as in communities and housing services. It's social care services, public health services, children's services and health services. So that's months in the kind of making, but what you then land with is a single defined model of neighbourhoods. And then from that, you can start to develop your population profiles. You can start to identify high areas and hotspots of service use across all of those public services. You can then start to connect the staff team so that they come together, share that data and insight to then work through what they need to co-design, co-deliver. So there's kind of a step-by-step process in terms of what then means that you're actually doing this in practice. So I think what I wanted to share was, I suppose, not to underestimate the amount of not only leadership, but then organisational development that comes with that. So examples such as the fact that teams have different approaches to risk. We have referral thresholds, we have commissioning policies, all of which need to then be worked through so that we can align those incentives. But the prize is worth it. You know, so just to really kind of bring home the extent and actually the support this will give to the design for the future work. So we heard Anya in terms of the key considerations that we will be working through as a group of system leaders. The neighbourhood model is absolutely at the heart of that.
Yeah, I agree. Really quickly, Stan.
I'll just quick, but I don't want to introduce another level of complexity, but neighbourhood is where we live, but it's often not where we go to the doctors. And I think there's a skewing and a distortion of data in here, in the patients list and doctors and where people live are starting to drift a long way apart. And I mean, my personal example, I'd say very proudly I've been with the same practice since birth. But that practice is nowhere near where it was when I was taken there as a child. It's moved 4 places. It's completely the other side of town. It's nowhere near where I live. Now, I think we need to understand whether that's a problem and whether digital is part of the solution to that problem.
Yeah.
But it's something that's not mentioned. Like this, I'm reluctant to mention it because I don't want to open a hornet's nest, but it is something we have to really understand.
Yeah. I'm so encouraged hearing that. I think it's a long time since I've heard this story. I'd love to see a maturity matrix which says, of the 42 PCNs, where are we at with all of those? And I do think this is exactly what a community, I'm going to say it the wrong way again, aren't I? Community health service or whatever, Wes spoke of, is exactly what he's talking about. So I feel like we are on the money with this. I think it's really encouraging. And it's this kind of work that we need to find a way to invest in the year ahead. Years ahead, isn't it? When we're looking at priorities in terms of where we spend our money, because this absolutely is the way forward, aided by digital and all of those things. So thank you very much indeed, Alex. You could have done with an hour, really, couldn't you? I am going to move on now, Pete, to you. This is the Children's Plan Framework Update.
So I'll give you the update with brevity. Then I want to land a point. We've got a plan. It's been approved. Priorities been socialised through all our networks. We had a challenge workshop last week, which was really well attended, to challenge the ambition that we have within the children's plan, and we expect to be bringing it back to this partnership for approval in the next meeting. So that's the kind of things. There are things we need to, and we continue to work with our directors of children's services on that. Things that need strengthening. We need to strengthen the children's voice in this. We have plenty of existing forum, youth councils, parent carer forums, child and care councils. We need to use those. We're signing leads from across the system so that it feels like a system plan. We're getting our outcomes framework written down. So the things we measure are the things, not hundreds of things, but the things which tell us about children's experience. That then means we need to rethink our governance arrangements through the Startwell board, and more than anything, we need to have some urgency around this. So to illustrate that last point, just remembering who we are talking about here. I was in one of the front doors of Children's Services, which is an integrated front door, not far from where you asked that, where we have social work, health, police, and at times education working together for children who are in need of help and protection. And I think if you just stood in that environment and just positioned ourselves again for what it's like for some children growing up in Humber, North Yorkshire, we would double our efforts on this agenda. And that's before you work our way back through children with profound disabilities, SEND, right the way back to immunisations and making sure that children have that genuinely start well in life. So I just sort of make that plea that when we think about how we reboot the ICP, if we are serious about this being our golden ambition, then we will demand to see a line of sight as to what are we doing. And the last point I'll make is, it's the same point I made at the Futures Group this morning, that when we fail, that failure echoes down the years. So so speech and language needs at primary school too often become behaviour needs at secondary school. Behaviour needs too often become needs too often become substance misuse, mental health needs, justice system. You can see it rolling down the years. So yes, it's an investment in the now, which is Mark's point about the urgency of everything else, but we have to carve it out.
Yeah, we absolutely do. We absolutely do. And we know that this is a huge priority for us, don't we? We have to do work in this domain. It's crucial. Yes, it's to the very heart of what we're seeking to do. So thank you, Peter. More coming back, I think you're saying, aren't you? I don't think there were any matters of any other business, were there? It's only raised for me to say thank you all very much indeed for coming. I think I've explained to you that we expect to do some review of the ICB and the ICP. The ICP is going to be an increasingly important part of what we do in terms of our work, but we'll probably have to refresh our view of how we manage the ICP. So we'll keep you posted on all of that. Of course, I wish you all a very happy Christmas and a very peaceful, prosperous, healthy new year. And if you'd like to have a mince pie just as you're leaving, please do. Thank you all very much indeed.
Thank you.
Thank you.